Failure Association of ESC?
2024.
25 was the last one.
25 you said? 25 years is 8.
You look at 2025. So, contemporary management of heart failure with reduced ejection fraction has impacted survival, hospitalization rates, and quality of life. Trials have demonstrated early benefit from prompt initiation and large benefits of comprehensive heart failure therapies over time. Now, despite several positive landmark trials and guideline recommendations, real-world evidence has shown poor implementation of guideline-directed medical therapy in terms of limited initiation, up-titration, and long-term maintenance. Several barriers hinder the effective implementation of heart failure guidelines, including factors related to patient, caregiver, physician or provider, and healthcare services. Comorbidities, advanced age, perceived polypharmacy, and limited awareness of heart failure can affect adherence to treatments and contribute to clinical inertia in prescribing and optimizing medication. In this context, low blood pressure is among the most common perceived barrier to the initiation, implementation, and escalation of guideline-directed medical therapy, as many heart failure medication can have hypotensive effect. Indeed, a recent international survey conducted by the Heart Failure Association of the European Society of Cardiology across 91 countries showed that 66% of respondents identified hypotension as a major concern and 31% as a secondary concern. Often, hypotension identified by cardiovascular clinician not be a barrier of guideline-directed medical therapy initiation or maintenance, as it is asymptomatic or associated with minimal symptoms. In the context of no or few symptoms, GDMP for heart failure should be continued to realize the large clinical benefits. Interestingly, while low blood pressure in patients with heart failure with reduced ejection fraction is linked to worse prognosis, treatment with GDMP has been shown to weaken this association, highlighting the ongoing beneficial effect of treatment and heart failure therapy even in patients with low blood pressure. Major recent landmark heart failure clinical trials have reported that the relative impact of pharmacological therapy on clinical outcomes was consistent across all baseline blood pressure category considered for inclusion. This apparent contradiction highlights the complexity of heart failure treatment, underscoring the need for nuanced and personalized approach in managing patients with low blood pressure. In this regard, a recent Heart Failure Association consensus document on GDMP optimization highlights the importance of patient profiling, which involve tailoring medical therapy based on clinical characteristics such as blood pressure, heart rate, and the presence of comorbidity to guide the initiation and up-titration of treatment. Now, prevalence of low blood pressure in the heart failure with reduced ejection fraction population. Now, low blood pressure depends on factors such as severity of heart failure, the presence of comorbidity, age, gender, and clinical presentation. And low blood pressure is identified as absolute systolic blood pressure less than 90 mmHg or mean arterial pressure less than 65 mmHg at rest. The presence of orthostatic hypotension is defined by sudden drop in systolic blood pressure of more than 20 mmHg or diastolic blood pressure more than 10 mmHg upon standing. Hypotension, blood pressure less than 90 to 100 mmHg with clinically relevant symptoms such as dizziness, syncope, headache, visual disturbance, emesis or fatigue, or hypotension as a side effect or adverse event of GDMP or other medication. Notably, in symptomatic hypotension, the threshold for low blood pressure is often not clearly defined and may be arbitrarily chosen as individuals tolerate different level of low blood pressure differently. However, in clinical trial, the inclusion threshold for clinically relevant low blood pressure is always fixed, usually close to 90 mmHg to prevent dropouts and preserve the trial's statistical power. Around 3 to 4% of heart failure with reduced ejection fraction population have a low blood pressure in the outpatient setting. Among 18,677 adult patients monitored between 2000 and 2005 in the Health Improvement Network UK primary care database, the incidence of hypotension was 14% over a mean follow-up period of 3.3 years. This corresponds to a rate of 3.17 cases per 100 patient year, with notably higher incidence in women aged 18 to 39 years who experience 70.72 cases per 100 patient years. The prevalence of hypotension increases with the severity of the heart failure. Indeed, in patients with heart failure with reduced ejection fraction hospitalized for acute decompensation, the prevalence of low blood pressure is predictably higher than in chronic setting. Across heart failure registry, the prevalence of low blood pressure range from 9% in the ADHERE trial with systolic blood pressure cutoff less than 90 mmHg, 22% in the HFrEF trial with systolic blood pressure less than 110 mmHg, and 25% in the optimized HF trial with systolic blood pressure threshold of less than 120 mmHg. As expected in the acute heart failure population, the incidence of hypotension is consistently linked to the severity of the illness and the treatment being administered. Now, prognostic impact of low blood pressure on the patient. Low blood pressure is an important prognostic marker in patients with heart failure with reduced ejection fraction, as also demonstrated by inclusion in several risk models like PROMPT HF trial, score, the LIFE HF score, and Seattle heart failure model, in which they include the low blood pressure as the poor prognostic marker. On the other hand, when patients are on GDMT, the prognostic impact of low blood pressure is diminished in the heart failure with reduced ejection fraction patient. In the Swedish heart failure registry, the composite risk of cardiovascular death or heart failure hospitalization rose as systolic blood pressure decreased, showing 2.5-fold increase at systolic blood pressure less than 80 mmHg and 1.5-fold increase at systolic blood pressure 100 mmHg compared to systolic blood pressure of 120 mmHg. Notably, the association between low blood pressure and increased mortality was attenuated in HFrEF patient on optimized CDMT, suggesting that beyond illness severity, the higher mortality may also relate to fewer patients in this group reaching the target dose medication. Now, effect of heart failure treatments on blood pressure. Now, several heart failure treatment can lead to reduction in blood pressure, with the most significant decrease observed in the treatment involving ARNI groups. However, it is important to highlight that GDMT have been proven effective and safe across all baseline systolic blood pressure level, and the hypotensive effect of HFrEF medication diminished as the baseline systolic blood pressure decreases. In the soloist WHF trial, with effect of sotagliflozin on cardiovascular event in patients with type 2 DM worsening heart failure trial, which evaluated SGLT2 inhibitor sotagliflozin in 1,222 patients experienced recent episode of worsening heart failure. Treatment emergent hypotension was reported in 6% of the treatment arm compared to 4.6% in the placebo arm. Similarly, EMPEROR reduced trial, in which empagliflozin trial was done, in which 5.7% reduction blood pressure reduction in the empagliflozin group compared to 5.5% in the placebo group, which is almost equal. Significantly lower in DAPA-HF trial, in which 0.3% in the dapagliflozin group and 0.5% in the placebo group, low blood pressure was identified.
So sotagliflozin is only SGLT2 inhibitor?
There is also GI effect.
Sotagliflozin is dual SGLT, including SGLT1 as well as SGLT2.
Increasing BP trend was observed in EMPEROR reduced trial among asymptomatic HFrEF patients with lower systolic blood pressure 100 to 110 mmHg treated with empagliflozin, and in the Copernicus carvedilol prospective randomized cumulative survival trial in patients with systolic blood pressure 85 to 95 mmHg treated with carvedilol. Finally, the EMPhASIS HF trial, in which eplerenone in mild patient hospitalization and survival study heart failure trial, patient in the lower state of baseline systolic blood pressure 95 to 105 mmHg randomized to eplerenone showed an average increase of systolic blood pressure at 1 and 6 months of 2.8 8 mmHg compared to placebo, likely reflecting an improvement in cardiac function.
What is mild patient's hospitalization?
Symptomatic is mild.
Then why it was hospitalized?
They were not mentioned.
They must have mentioned kind of rule like sentence. Mild patient hospitalization survival study. Mild patient survival studies again कहीं काम अच्छे है कर लो
Among 8,399 patients enrolled in Therapeutic HF trial, 1,343, around 60% experienced asymptomatic hypotension, while 936 experienced symptomatic hypotension at least once after randomization. Importantly, the efficacy and safety of sacubitril valsartan were maintained regardless of the presence or absence of hypotension. This concept was further supported by post-hoc analysis of Therapeutic HF, which showed that benefit of sacubitril valsartan over enalapril were consistent across all baseline systolic blood pressure category, reinforcing the idea that low blood pressure should not hinder the optimization of GDFP. Low blood pressure events during heart failure treatment were understandably more prevalent in the acute setting than in chronic setting. In the ASCENT HF trial, evaluating the effect of necessitide in patients hospitalized for acute HF, 22% of patients had an in-hospital episode of hypotension, in which 73.1% were asymptomatic, with key factors including randomization to necessitide, chronic metalosome therapy, and severe illness indicators such as baseline orthopnea and S3 gamma. Now, low blood pressure in the clinical setting. Now, low blood pressure in patients with heart failure may occur with or without symptoms. It can happen in both inpatient or outpatient setting, though it is more observed during the hospitalization of heart failure, as previously mentioned. Hypotension can occur in various clinical contexts, including among patients new to heart failure treatment, during the initiation of therapy, and among those who receive the optimal or suboptimal medical management. In each scenario, it is essential to pinpoint the specific circumstances and timing of the low blood pressure episode, especially in relation to heart failure treatment, to identify and address all factors contributing to the hypotension. So, when patient of heart failure with reduced infection coming with low blood pressure, we have to evaluate the cause, which may be either cardiovascular related or non-cardiovascular related. So, cardiovascular related cause like advanced heart failure, decreased blood volume, in recent bleed or trauma with anemia, valvular disease, significant MRTR or AS, bradycardia, dehydration, increase in diuretic dose in the previous week, prolonged bed rest which may lead to orthostatic hypotension, pregnancy first 24 week, BP lowering medication like calcium channel blocker, alpha blocker, centrally acting, diuretic, thiazide, ACE inhibitor, ARB or beta blocker, angina medication like beta blocker, calcium channel blocker or nitrate, heart failure non-class 1 medication like hydralazine or nitrate, neurally mediated syncope, altered vasoreactivity related to comorbidity like diabetes, then acute rapidly progressive causes related to hypertension like pericardium cardiomyopathy, myocarditis, intra-abdominal hypertension, persistent sign of congestion requiring high dose of diuretic or vasodilator. Similarly, non-cardiovascular cause also should be ruled out before manipulating the treatment for HFrEF like elder age, CKD, endocrine problem like hypothyroid, adrenal insufficiency, hypoglycemia, diabetes, infection like UTI or septic shock, allergic reaction, nutrient deficiency like B12 or folate deficiency causing anemia, iron deficiency, hepatic cirrhosis, COPD, dementia, Parkinson, depression, and medication like antidepressant, antipsychotic, dopamine antagonist, phosphodiesterase 5 inhibitor, alpha blocker, complementary and alternative medication, narcotic, alcohol, and intraocular beta blocker, which are used in the glaucoma. So, cardiovascular or non-cardiovascular related cause should be ruled out. Now, effect of devices, interventional procedure, and non-class 1 drug on heart failure treatment optimization, which we are using in the heart failure patient, like cardiac resynchronized therapy, which improves the quality of life and reduce heart failure hospitalization and mortality in selected patients with HFrEF and left ventricular electrical dyssynchrony, they increase the average BP around 5%. Then transcatheter valve intervention and other procedure, like in relief of AS has been shown to significantly increase the blood pressure after the procedure. In partner world trial, which focus on patients with severe symptomatic AS and high or prohibitive surgical risk undergoing TAVR, 55% of participants experience an increase in systolic blood pressure 30-day post-procedure. Over 6 months post-TAVR, there was a moderate rise in systolic blood pressure of less than 10 mmHg and slight decrease in diastolic blood pressure of less than 5 mmHg. Another study involving 105 patients with severe AS reported an immediate post-TAVR increase in systolic blood pressure sustained over 5 days in 51% of the patients. Then transcatheter edge-to-edge repair of the atrioventricular valve can reduce backflow in the pulmonary or systemic circulation, thereby allowing congestion and enhance forward cardiac flow and perfusion. This may lead to beneficial effect on blood pressure, renal function, potentially facilitating the optimization of guideline-directed medical therapy. Then medication like ivabradine, which is the sinoatrial node IF channel inhibitor, which effectively lower the elevated heart rate in patients with sinus rhythm without adversely affecting blood pressure, which may instead show a slight increase in the blood pressure. Ivabradine can be particularly beneficial in patients with HFrEF, where low blood pressure limits the optimization or escalation of beta blocker, potentially enabling more effective beta blocker management over time, both in chronic and acute heart failure scenario. Notably, secondary analysis of HFrEF trial, systolic heart failure treatment with the IF inhibitor in ivabradine trial demonstrated that reducing resting heart rate with ivabradine is effective in improving clinical outcome for HFrEF patients with low systolic blood pressure. Second is digoxin, which is cardiac glycoside with inotropic properties and neurohormonal modulating effect by resetting baroreceptor sensitivity with subsequent parasympathomimetic and anti-adrenergic effect, resulted in increased cardiac output, afterload reduction and lower pulmonary capillary vein pressure in HFrEF patient. Currently, guideline recommended use in patients with HFrEF as second-line treatment for AF rate control in combination with beta blocker. Now, how to determine if low blood pressure is clinically significant or not? So, first, office BP measurement is required, in which obtain blood pressure in the supine or sitting position and standing position for 3 minutes to determine if the patient has orthostatic hypotension or not. If symptoms during confirmed orthostatic hypotension, then it is symptomatic hypotension. Second, arterial blood pressure monitoring measurement can be considered if orthostatic hypotension is not identified with office blood pressure measurement. Then correlate symptoms with low blood pressure episode on arterial blood pressure monitoring. If correlated, then symptomatic hypotension is present. Then reassessment. If initial office blood pressure or arterial blood pressure monitoring did not identify symptomatic hypotension, consider repeated evaluation during follow-up. In all cases, even if no symptom related to hypotension, address factor triggering hypotension unrelated to HFrEF, like transient medical condition like diarrhea or fever. The use of cardiovascular treatment not recommended for heart failure with induced ejection fraction. Now, low blood pressure in ambulatory patient with heart failure, which is new to therapy, in which we have to start the therapy. If a patient's blood pressure normalized after initial intervention by modulation or discontinuation of non-heart failure hypotensive treatment, GDMT should be promptly commenced according to heart failure guidelines. For persistent low blood pressure in asymptomatic or mild symptomatic patient with HFrEF and adequate perfusion, a low dose sequence of heart failure medication may be started. Since SGLT2 inhibitor and mineralocortical receptor antagonists have the least effect on blood pressure but a rapid beneficial effect, this should be initiated as the first drug class. Subsequently, consider starting a low dose beta blocker if heart rate is more than 70 beats per minute, or a low dose or very low dose sacubitril valsartan, then gradually up titrate if possible. In case of poor tolerance to sacubitril valsartan, a low dose ACE inhibitor or ARB if ACE inhibitors are contraindicated should be considered. Selective beta-1 receptor blocker may also be preferred due to lesser BP lowering effect than non-selective beta blocker with alpha beta-1 and beta-2 blocker or vasodilator property. If beta blocker are not well tolerated hemodynamically, then ivermectin may be viable alternative either alone or with low dose beta blocker, and it help facilitate the titration. So in chronic heart failure setting, first we have to confirm the low blood pressure by office blood pressure measurement or arterial blood pressure measurement. Then we have to assess the symptom and severity of patient condition. Then we have to determine etiology of low blood pressure, either cardiovascular or non-cardiovascular. Then consider decreasing or stopping antihypertensive non-class 1 HFrEF medication, nitrate therapy, antiarrhythmic, neuro or psychiatric therapy, drugs for erectile dysfunction, BP lowering for BPH therapy like alpha blocker. We have to consider decrease or stopping that medication which have effect on the blood pressure. Then if consider the decreasing diuretic in hypo or euvalent patient. If after that much measure, if persistent low blood pressure is present, and if patient is new to therapy and with asymptomatic or low blood pressure with mild symptom, initiate with SGLT2 inhibitor or mineralocortical receptor antagonist, then add low dose ARNI or ACE inhibitor or beta blocker depending upon the condition. Then initiate the remaining drug and up-titrate the therapy as per the patient symptoms or blood pressure on the follow-up. If patient new to therapy and with symptoms with low blood pressure, then we have to refer to the heart specialist or advanced heart failure program for evaluation. If patient with persistently low blood pressure which is already on medication for HFrEF, if patient is asymptomatic or low blood pressure with mild symptom, then we have to not down titrate or stop GDMT. We have to continue with that medication. If patient with low blood pressure with major symptom, then we have to initiate GDMT down titration process. Then low blood pressure in ambulatory patient with heart failure under treatment. Similarly, symptomatic hypotension in chronic HFrEF, typically characterized by mild dizziness upon standing, can usually manage through patient education and counseling without necessary reduction in heart failure pharmacotherapy. Patients often feel reassured and remain compliant to their treatment regimen when they understand that transient dizziness is a side effect of life-prolonging heart failure drugs, which also reduce hospitalization and enhance quality of life. As a rule of thumb, patients who are clinically stable on optimal medical therapy but with low blood pressure, whether symptomatic or asymptomatic, are unlikely to have their condition directly caused by GDMTs. This common scenario should promptly lead to an evaluation or other potential cause, both cardiovascular and non-cardiovascular, to avoid unnecessary interruption, reduction or discontinuation of foundational HFrEF therapy as outlined above. So the first step in this setting should be assess the congestion status to assess the feasibility of possible diuretic dose reduction. Clinical biological ultrasound sign of congestion should be explored to attain this goal, and in the absence of congestion, diuretic could be cautionally decreased. Although only a few trials have focused on reducing diuretic, a recent randomized controlled trial has shown that this approach is feasible in stable patients with HFrEF. Now, in patients presenting with acute heart failure, most patients in the acute setting are congested and well perfused, wet and warm phenotype of Forrester classification, thus showing no contraindication to either continue or initiate GDMT after reaching the clinical stability. In case of acute heart failure with low blood pressure, it is crucial to explore cardiogenic shock defined by systolic blood pressure less than 90 mmHg coupled with sign of organ hypoperfusion, as the treatment approach will differ the respective guideline. Notably, it should be borne in mind that during the initial phase of cardiogenic shock, hypoperfusion may occur without hypotension, as blood pressure may be maintained to compensate the vasoconstriction at the expense of tissue perfusion and oxygenation.
How is the first statement justified? Most patients in acute setting are congested and well perfused.
Most patients, not all patients. So
most એટલે major ને
yes,
major patient heart failure with reduced ejection fraction વાળા cardiogenic acute heart failure માં આવે તો well perfused હોય. રેફરન્સ શું છે આ સ્ટેટમેન્ટ?
But they have given the guidelines for that.
પણ તમારું શું માનવું છે?
In a
Congested
why they are well confused because of the tachycardia.
tachycardia.
Low blood pressure with increased heart rate, if you multiply cardiac output stay. A moment you reduce the
સેકન્ડ સ્ટેટમેન્ટ જ લખ્યું છે કે તમારું પેલું કમ્પેન્સેટરી મિકેનિઝમને લીધે બ્લડ પ્રેશર નોર્મલ હોઈ શકે, પરફ્યુઝન નોર્મલ, વેલ પરફ્યુઝ ઇઝ લિટલ ડાઉટફુલ, રાઈટ? ટેકિકાર્ડિયા ને બધાને લીધે તમારું બ્લડ પ્રેશર મેન્ટેન હોઈ શકે, પણ પરફ્યુઝન ઇઝ અ ડિફરન્ટ સ્ટોરી. અને વેલ પરફ્યુઝ હોવું તો કઈ રીતે કહી શકો તમે? એ મોસ્ટ પેશન્ટ
If you keep the blood pressure more than 90 or 90, 100, then most of the time renal perfusion and cerebral perfusion stay.
Last sentence should be notably it should be borne in mind that at the initial phase of cardiac arrhythmias, hypoperfusion may occur without hypotension.
ये बात नीचे
એટલે વેલ પરફ્યુઝ મોસ્ટ પેશન્ટ હોત તો વાર્તા પૂરી થઈ જાય ને, તો મારી બધી માથાકૂટ શું કર્યું?
As BP may be maintained below compensated vasoconstriction at the expense of distribution.
હવે બોલો.
ये hyperperfusion intention ultimately tachycardia થાય એટલે શું છે at the cost of intestinal perfusion. Intestinal perfusion suffer because of vasoconstriction. Skin perfusion suffer vasoconstriction.
During the initial 48 hours of hospital admission, the primary goal are to stabilize patient hemodynamically, treat volume overload and congestion, and ensure adequate tissue oxygenation. At this stage, the continuation or initiation of GDMT should be evaluated according to the clinical phenotype. Typically, in the dry and cold and wet and cold acute heart failure phenotype, heart failure therapy may be withheld or reduced, especially beta blocker and or renin-angiotensin system inhibitor. After the first 48 hours, heart failure treatment can be initiated, reinitiated or up-titrated based on the evolving clinical scenario and the specific patient characteristic, optimal or suboptimal GDMT or de novo acute heart failure. Typically, it is best to start or restart medication that have least impact on blood pressure like SGLT2 or low-dose mineralocorticoid or receptor antagonists, then gradually introduce other drug to conservative up-titration. This early optimization focus protocol is supported by the finding of strong HF trial, which demonstrated that intensive treatment strategy involving the up-titration of GDMT to 100% of recommended dose within 2 weeks of discharge and close follow-up after acute HF admission significantly reduce symptoms, improve quality of life, and decrease all-cause mortality or heart failure readmission at 180 days compared to usual care strategy. So, when patient with symptomatic low blood pressure on optimal or suboptimal therapy, then we have after excluding other causes, we have to de-escalate the therapy depending upon the patient clinical data. If EGFR is less than 30 ml per meter square, then reduce the RAS inhibitor and mineralocortical receptor antagonist. If potassium is more than 5 milliequal per liter, then reduce the MRA and RAS inhibitor. If heart rate is less than 60 blood pressure, 60 beats per minute, then reduce or stop the evaporating beta blocker and consider the pacing like CRT therapy. If patient has history of severe arrhythmia, then we have to decrease the RAS inhibitor or MRA. If heart rate is more than 70, then reduce the ACE inhibitor, ARB or ARNI and reduce the MRA. When patient has no specific clinical profile, then decrease the RAS inhibitor or beta blocker. Maintain the SGLT2 inhibitor, which have very limited blood pressure effect. After considering that much, then if persistent low blood pressure with major symptoms, then refer to heart failure team for advanced therapy. Then replace the carvedilol by metoprolol or bisoprolol, which have less effect on the blood pressure. If ARNI not tolerated, replace with low dose ACE inhibitor or ARB. If blood pressure improves, then reinitiation phase start. If EGFR is less than 30 ml per meter square and heart rate less than 60, then we have to add the SGLT2 inhibitor if not already on with EGFR more than 20 ml per meter square. Blood beta blocker up titrate if heart rate more than 50. Reinitiate beta blocker or up titrate if EGFR is less than 30 with adding of SGLT2 inhibitor, then initiate MRA or optimize if already not on suboptimal dose. Initiate ACE inhibitor ARB, RB or uptitrate them, and beta blocker uptitrate if heart rate is more than 50 per minute. Then reinitiate beta blocker or uptitrate if EGFR is more than 30 ml per meter square and heart rate more than 60. Then secondly, add the initiate ACE inhibitor ARB, RB or uptitrate is their medication.
ઘણા કેચ પોઈન્ટ છે કે EGFR માનો કે 25-30 હોય મારો પોટેશિયમ લેવલ ખાસું વધઘટ હોઈ શકે છે સો એ ક્યાંક નોટ હશે ફૂદડી કરી શકે
And potassium reduce if more than 5, then we have to reduce MRA acid.
તો એ હોવું જોઈએ.
So gaps in evidence and research publication. Major heart failure clinical trial typically enroll patients with normal blood pressure, leaving those with very low blood pressure like systolic blood pressure 90 or 95 mmHg, which is notably underrepresented. Evaluating the effectiveness and safety of GDMT in patients with very low blood pressure, particularly when using medication like ACE inhibitor, ARB or RB that significantly lower blood pressure. Testing the proposed low blood pressure management strategy to provide randomized evidence in support of this expert concession. Investigating the impact of discontinuing non-life expanding medication to enhance GDMT outcomes, focusing on overall patient survival, quality of life as well as potential benefit of reducing diuretic to decrease the heart failure related events including hospitalization. Third, assessing the effect of interventional cardiac procedure like CRT, TAVR and mitral or tricuspid transcatheter H2H repair and the restoration of sinus rhythm in patient with AF on blood pressure, GDMT optimization and outcome in patient with heart failure and low blood pressure. So take home message, asymptomatic or mildly symptomatic low blood pressure should not be reason for GDMT reduction or cessation. Reduction or cessation of one or more GDMT is advisable in case of systolic blood pressure less than 80 mmHg or low blood pressure with relevant symptoms. In chronic heart failure, always evaluate symptoms of hypotension or orthostatic hypotension. In acute HF, always assess organ perfusion. The blood pressure threshold as an exclusion criteria in clinical trial is primarily set to prevent dropout and maintain the trial statistical power. SGLT2 inhibitor and MRA have the least effect on blood pressure, and in low blood pressure group they may increase the blood pressure. In specific condition, other drugs or device may be appropriate to facilitate optimization of GDMT like ivabradine, CRT, transcatheter H2H repair, digoxin. In low blood pressure condition, the first step is to stop unnecessary cardiac medication and then look for transient and reversible causes. Multidisciplinary care coordination of selection of appropriate alternative with lesser blood pressure lowering effect of non-cardiac medication like medication for prostate hypertrophy, antidepressant which may lower the blood pressure. When discontinuation or reduction of therapy is needed, start with the less tolerated. In persistent hypotension with inability to initiate or titrate GDMT, refer early to heart failure specialist or advanced therapy programs. When blood pressure improves, always consider reinitiation or re-challenge of drugs based on better tolerated first. Strive to achieve optimal therapy with space medication in divided doses throughout the day. Give selective beta blocker or consider ivabradine. If RA not tolerated, try to introduce and optimize ACE inhibitor or ARB.